Thank you for quoting this long title. Well, Mr. President, dear colleagues, last year when the EVAR-1 trial results were published, it was suggested that these, based on these results, open repair should actually, based on this long-term follow-up data, be preferred over endovascular repair for AAA treatment. I will show you in the next few minutes that these results can also be interpreted in another way. Indeed, when we look at these figures, in the early phase after endovascular or open treatment, there was an advantage in the EVAR-1 trial for endovascular treatment, but after more than 8 years, there seemed to be an advantage for open repair. Looking at the raw figures, this was significant during the first period. Then there was a long period in which there was no significant difference, but only after 8 years, as I said, there seemed to be a difference in favor of open repair. But for the whole group, when we're looking at all patients, this difference was not present, or at least was not significant. Presented in another way, as death rate per 100 patient years, these are the figures: overall mortality 9.1 versus 8.9% per 100 patient years for overall mortality, and a similar result for aneurysm-related mortality. Both results are not significant. However, we believe that there should be another way these results should be interpreted. Indeed, what is important when treating such a patient with a AAA is how many life years can we save? Or on the other hand, how many life years are lost because of this pathology? And to do this, it's important to know when the patient actually died. Because it's much more important when a patient dies after 2 years of follow-up, for instance, then he loses 13 years. When a patient dies after a longer time, after 10 years, for instance, then he only loses 4 years or 5 years. And this is an important difference, of course. So when we do perform this analysis and we look at the number of life years lost, which is actually represented by the area above or below the curve, then the results are different. They're not significant either, but in an estimation, the overall mortality in this time was in favor of EVAR, and the same is true for the aneurysm-related mortality. And this is reflected in the median survival after EVAR, which was indeed longer than after open repair. The authors of this article quoted as reasons for the results, the long-term results, the fact that there were more secondary aneurysm sac ruptures after EVAR. And most of these secondary aneurysm ruptures were associated with some well-known risk factors, conditions that actually can all be diagnosed very easily during follow-up. So the question is, was this long-term follow-up adequate? Well, Professor Greenall already showed that this was not the case, with only a small number of EVAR patients having had even a duplex scan, and most of them did not have a CT scan beyond a period of 10 years. So there was clearly a need for better follow-up. Another reason for the higher mortality rate in the long term after 8 years was the increased cancer mortality, which was suggested. And indeed, looking at the period above 8 years, there seemed to be more cancer deaths in the EVAR group compared to the open repair group. And of course, this is a very sexy observation, because it would suggest that the radiation with the EVAR procedure and follow-up could induce these cancers. However, when we look at the whole group, in the previous years, there were less cancer deaths in the EVAR group compared to the open repair group, so that over the whole period, again, there was no difference. So the right conclusion probably is that EVAR patients get cancer later than the other ones. So maybe EVAR even prevents cancer in the early period after intervention.
Heard that before.
Looking at the number of re-interventions, it's clear, of course, we do need more re-interventions after EVAR than after open repair. But these also are mainly during the early period, and what we cannot forget is that all these procedures, the time period in which the EVAR procedures were performed was between 1999 and 2004, so these were all performed with older generation stent grafts. And we know, for instance, from this study from Italy, that it is important to have these newer stent grafts, that the complication rates are lower. They can be reduced by 36%, 1/3, compared to the older stent grafts group. And also this study from New York showed similar results, comparing different time periods, different prostheses that were used, reducing the aneurysm-related death rate as well as the reintervention rate significantly when comparing the different periods. And this is also illustrated in this real-world registry, the ENGAGE registry, which was already quoted, where you see that the 4-year freedom from reintervention rate was 87%. And at last, in this time of patient preference evaluation and concerning the fact that this is an important issue also, this study performed by Professor Greenall actually showed that when you ask patients for their preference after them being informed, clearly the patients prefer EVAR over open repair. So as a conclusion, Mr. Chairman, dear colleagues, I think we can state that even after 15 years, EVAR is at least equivalent to open repair with regard to life saved by the interventions. Contemporary reintervention rate with newer generation grafts is lower than in EVAR 1. Adequate and continued follow-up, though, remain mandatory. There is a need for methods that reduce total radiation burden during procedure and follow-up, and EVAR remains the first choice for doctors as well as for patients with suitable anatomies.